Good evening, everybody. You are welcome, all my colleagues, on this prestigious website for continuous education of ophthalmologists worldwide. It's my honor and pleasure to be here and present this interesting topic with you. Today, we are going to talk about advanced glaucoma. What is the current management and practice? This topic, before we start, we have to highlight some points in a poll here. Regarding the advanced glaucoma, how are we going to define these cases? We have options like here. Please select your choice and we'll see, to test our knowledge before we start the session. I see now from the poll that most of you, I think about 53% has defined advanced glaucoma as those patients with near total cupping of the optic nerve head with severe visual field loss, with a center 10 degrees of fixation, and about 33% choose all the above. But the most important point here to clarify is that definition of advanced glaucoma are those with no near total cupping of the optic nerve head with or without severe visual field loss, as sometimes some cases of normal pressure glaucoma presents late with advanced visual field damage, despite the fact that they lose a lot of the optic nerve head and the retinal fibrillar earlier in the disease. Go to the second question, please. The second question, how are you going to follow up such a kind of advanced glaucoma patients? We have 4 choices using either imaging modalities, which is so advanced now, visual field exams, all of the above or none of the above. I think we have chosen all of the above, but during the course of the presentation, we will understand that the imaging modalities, despite the fact it's so advanced now, it is not enough to follow up this kind of patient, as nothing remains from the structure integrity of the optic nerve head and retinal fibrillar layer to follow up with. And the most important is to concentrate in the optic nerve head, in the visual field. The third questions, what is the best management option for advanced glaucoma patient? We have several modalities of treatment like medications, laser, trabeculectomy with adjuvants, and all have to choose all of the above, because it's very important to test the current practice in different parts of the world and with different we see that 54% of the audience chose to do all of the above, a mix of all the above medication, which is close to be right. And the next consensus comes 34% choose to do trabeculectomy with adjuvant medication, which is the most important part in management in this kind of advanced glaucoma patient. Lasers and medication plays a very little role, as we will clarify later on the course of the presentation. The last question will be, if you are encountered with a new case of advanced glaucoma, what is your primary option? To do medication, do laser therapy, minimally invasive glaucoma surgery, or to do trabeculectomy? I see that 32% choose trabeculectomy and 46% choose to do medication, which is not. We hope at the end of this presentation to get out of this percentage and to transfer it toward the trabeculectomy or the minimally invasive glaucoma therapy. But medication has, of course, a very limited role in this kind of management. Now we go. Advanced glaucoma, what is the magnitude of the problem and why is this group of patients are important? Simply, we could say that this increased morbidity and mortality of this group of patients. They are at great danger of losing the remaining vision, and this disease affect a broad array of our daily activities with various socioeconomic and health challenges such as stigmatization, underemployment, or non-employment, and this increased risk of driving accident, falls, as well as mental and health difficulties, including depression. If we come to the annual cost of glaucoma per patient in the United States, we could see here it varies between the different stages of glaucoma. For example, in advanced glaucoma, we could see that it varies between $2,500 per year per patient, in comparison to $1,500 per year in the early stage of glaucoma. And we could see that the distribution of the cost, these are new modalities of treatment comes to in the advanced glaucoma, late advanced glaucoma, which is the low vision aids. And we could see how much it differs as a cost and the management shifts in this presentation between the early, which is very limited, the blue ones here, and the late stage of glaucoma, which is that much larger in the advanced glaucoma in that stage. If we come to the epidemiology of advanced glaucoma, we could say that there is a significant portion of glaucoma patients presents late in advanced stage of disease in the developing and developed world. For example, in the United Kingdom, 38% of patients of newly diagnosed glaucoma patients were in the advanced stage of glaucoma, while in the South Africa, 45% of those with glaucoma were blind, at least in one eye, at the time of presentation. What about the underdeveloped world? We should understand that the magnitude of this problem is very large in these people. What should you know about advanced glaucoma? We should know how to define this disease, how to diagnose and follow up, what are the challenges, what is the target intraocular pressure in these cases, how to treat medically, laser or surgery, or a mix of both, what kind of surgery are you going to do for these precious patients and why? If we come to the definition, we could say that patients with advanced glaucoma are those with near total cupping of the optic nerve head with or without severe visual field loss within center 10 degrees of fixation. And these patients tend to have worse visual prognosis and as overall. Based on the Hodab-Barish and the Anderson criteria, we should know that this is the classic definition of advanced perimetric glaucoma, which is a mean defect more than 12 decibels. In the corrected band standard deviation, 50% of the points are depressed at B less than 5%, or 20% of points at B less than 1%. At least 1 point center 5 degrees with a sensitivity of 0 decibels and point with center 5 degrees with sensitivity less than 15 decibels in both hemifields. But this applies for perimetric glaucoma, perimetric advanced glaucoma, but we have a non-perimetric advanced glaucoma in these patients, specifically this patient with normal pressure glaucoma, in which the breakthrough in the visual field occurs later in the course of the disease. What are the risk factors in advanced glaucoma? We have to know that we have a ocular and non-ocular risk factor. Within the ocular risk factor, we had those with strong evidences and those with moderate strengths. Those with strong evidences of advanced glaucoma, advanced structure and the functional loss at the initial presentation of the disease, and also the patient with high or marked visit-to-visit intraocular pressure fluctuation. These patients are at great danger of advancement of the disease. Also, we should know that the socioeconomic condition and the background and the poor compliance of the patient play an important role as a part of the non-ocular risk factor. In addition to other factors, as disc hemorrhage, syncornias, and this damage of the fellow eye and poor compliance, these are the most important point to highlight. How are you going to detect and follow up glaucoma? It varies between the patient's symptoms, identify of any secondary cause, we have to be corrected, monitor structure and function, imaging devices, how are you going to use, visual field changes, how are you going to use it, and long-term follow-up and subsequent visits. We could say that the subsequent visit for advanced glaucoma with a stable glaucoma, it should be between 3 and 4 months, and it could be more frequent if unstable condition in order to detect changes and to deal with it swiftly. If we come to the patient symptoms, we have to listen carefully to the patient and to compare his previous and past experience with the current experience. Sometimes the patient will describe I'm not able to see part of the words I used to see earlier. I'm missing part of the words while I'm reading. I bump into things more often than earlier. Transient visual field loss and visual hallucination are a very important symptom, and we have to listen to the patient. And it's very important to know, is this patient is progressing or stable? Stable patients usually don't miss words more than often and don't bump in things more than previous, and progressing one are losing. If we are going to use the structural changes in the optic nerve head and retinal nerve fiber layer to follow up such a kind of patient during our clinical exam, we could say we have to find this hemorrhage, which is transient either in the neuroretinal rim area or in the nerve fiber layer as subsequent development of such a kind of things. We could say it is difficult to assess because simply is subtle change in the optic nerve head remains because the neuroretinal rim area only very limited part is left, and it is hard to find subtle change in this part. And visual field change are less correlated with the structural change specifically in the optic nerve head in such a disease. If we are going, we have to carefully examine the zoom beta peripapillary atrophy. If we could compare that this is the cup disc ratio in both eyes, and we could compare the defect in the zoom beta and how is it getting enlarged from the left picture to the right, we could see that it is enlarging with advancing disease. If we come to the most important spectral domain, the OCT machines, which can measure precisely the optic nerve head and retinal fiber layer and even the ganglion cells, we could say that if we look, patient doesn't look similar, despite the fact in these two patients are closely similar if we examine the spectral domain, optic nerve head and retinal nerve fiber layer parameters. But if we go to the visual field, we see that the left one is more healthier than the right one. So it is not likely to be helpful to use such an advanced machines as this minimal neuroretinal rim area and retinal fibrillary changes happens in this stage of the disease. If we say that we have the new modality which measures the ganglion cells, we could understand from this graph here that early in the disease, while the visual field changes from 0 loss to 3, some patient will lose between an amount of the ganglion cell between 140 to 60. This is early in the disease. Early in the disease, the structure changes is very helpful and important, and you can use the ganglion cells to detect, because the changes in the structure is more than the change in the function. Later on in the disease, in the moderate and severe glaucoma cases, we could see that the changes in the moderate cases between 3 and 10 or 3 and 12 decibel loss, we could use both, a combination of both. But later on the disease, we could see the changes from 12 to 30. There's only a limited range of ganglion cell loss between 40 and 0, which is complete loss of the ganglion cells, which is not present or never exists in reality. So early in the disease, we could use both structure changes and machines used to image the ganglion cells and retinal fiber layer and the optic nerve head assessment. Later on in the disease, we have to resort to visual field, which can give us a better idea. If we are going to use the visual field, what kind of visual field are you going to use? It might be the only possible way to follow up such a kind of patients, in addition to the clinical symptoms of the patient. We have to resort to central 10 degrees of visual field examination, use Goldman size 5 instead of 3, to clarify the defect, examine the cardinal points around fixation, and or use the quadrant total sensitivity. And we'll come to it. If we are using the CETA 24-2, we are examining 12 points, which is 6 degrees apart, as you see here. If we use the central 10 degrees, we are examining 68 points with 2 degrees apart, with more detailed examination, as we could see, and what we are missing in the standard visual field. If we come to this graph, we see here that if we are examining central 10 degrees, we are this red marked points here, as you could see here, and you see no defect in the grayscale presentation. If we examine with the central 10 degrees, we could see that the defected points is residing in between the examined central point in the central 24-2, and we could find the defect. So every patient with advanced glaucoma, whether he has a central island or not, we have to do, or even every patient with glaucoma, we should do central visual field 10 degrees exam. As this patient, which has no defect at all, it shows a central defect in the disease, in the central 10 degrees. We could see here, if you look to the grayscale, it's very limited part. If you look at the top figures, it's very limited. If you magnify it, you could have more view down, as you could see here. If you use stimulus size, you see it's completely in a case which is totally dark here. What are you going to follow up with? Nothing to see. It's you will neglect it. But if you magnify it with central 10 degrees and used stimulus size 5 instead of stimulus size 3, you could find more details to follow this patient in a numeric and objective manner later on. Also, you have to resort either to examine the quadrant total sensitivity here, which is a very important point in central 10 degrees, which is existing in the Humphrey visual field, or to compare point-wise comparison. This point was defective by 5 decibel, now it is defective by 30 or so, so it is to compare it point-wise, as you could see here. What are the challenges in advanced glaucoma? We have several challenges here for sure. One of them is the low target intraocular pressure we have to reach, and we need to gradually decrease the intraocular pressure post-operatively, and also the high incidence of post-operative complication, and we should avoid it. Such patient with advanced glaucoma is typically characterized by anxiety, fear, and sometimes hopelessness and depression. Also, the physician might also feel that they are in a difficult position managing such a kind of precious patient. So we have to avoid loss of the remaining portion of the vision, in addition to maximally control the intraocular pressure, which is a very difficult task, but it could be reached, no problem. Regarding the target intraocular pressure, it is a theoretical level at which no further damage to the optic nerve head and retinal fiber layer and the visual field will happen. In advanced glaucoma, lowering the intraocular pressure to the low teens, 12, 11, 13, or even the upper single digit 9 or 8 is very important. Reducing the intraocular pressure fluctuation is very important. Both of these two factors, low intraocular pressure and no or little fluctuation, has the strongest evidence of protecting the optic nerve head and the remaining visual field later on. Other strategies like enhancing the blood flow and neuroprotection might be helpful for sure, but it lacks a solid evidence-based and application. And how are we going to increase the ocular blood flow? Our capabilities is limited. What is our mechanisms of neuroprotection? Our mechanisms are very limited. So the only neuroprotective mechanism here is lowering the intraocular pressure and reducing the fluctuation of the intraocular pressure. If we come to the management strategies, we should address several points. One of them is the biosociospiritual profile of each patient should be addressed. Aggressive lowering the intraocular pressure, medical therapy, laser surgery, trabeculectomy, glaucoma drainage devices, and the new modalities of minimally invasive glaucoma surgeries. If we come to the biosociospiritual profile of each patient, we should address the mechanism of glaucoma. Normal patient glaucoma management is different from high pressure glaucoma management and totally different from secondary glaucomas. General health and systemic condition and other ocular risk factors like cardiac disease and patient with bronchial asthma should be addressed because it will affect our choice of medication and our condition if we are going to submit the patient for surgery. Age and life expectancy of the patient is very important. Psychological condition, socioeconomic status, patient care, and partners should be counseled carefully how to help this kind of advanced glaucoma patients and to counsel them about the danger of disease and its importance. Aggressive lowering of the intraocular pressure is very important. It is the only proven treatment in preserving the visual function in glaucoma. No other ways till now we could assess it carefully. In the advanced glaucoma intervention study, patients that didn't progress had a mean intraocular pressure of 12 millimeter. Very low intraocular pressure was needed in order to maintain the visual functions in advanced glaucoma patient over a long period of time. Fluctuation of intraocular pressure should be considered whenever a patient with apparently lower office measurement of intraocular pressure demonstrates a progression in the disease. If you are following your patient carefully and in each visit you find that the intraocular pressure is stable and he is progressing, you should think about fluctuation of the intraocular pressure, and you could do a diurnal curve every now and then. And also you should address the other factor like how is he going to use the medications for his blood pressure and so on. Medical therapy. Is medical therapy indicated for advanced glaucoma patient? We could say yes. In some patients, it has a place to be applied, specifically in patients who are progressing slowly and may have longevity such that they might not got blind during their lifetime. And patients who can afford the medication, medical therapy may be an appropriate option for such a kind of patient. But patient who cannot afford the medication, if the medication is not available regularly, and the patient with long life expectancy, and the progression of the disease is rapid, these patients are not candidate for medical therapy. How are you going to prescribe medication for such cases? We have to prescribe medication with less fluctuation of intraocular pressure, like prostaglandins, carbonic anhydrase, beta blocker. Brimonidine and its neuroprotective effect could play a role here, but it's not that much. Laser treatment. We have in our armamentarium of anti-glaucoma laser therapies a lot of weapons here, from the laser trabeculoplasty, selective laser trabeculoplasty, transcranial cyclophotocoagulation, and the new modalities of laser like micropulse laser and subthreshold lasers, and endoscopic cyclophotocoagulation. We could say that any kind of laser that has the potential to increase the intraocular pressure postoperatively should be avoided, like laser trabeculoplasty and selective laser trabeculoplasty. Transcranial cyclophotocoagulation could be employed in some cases, especially advanced glaucoma cases with morbid conditions. Micropulse laser could have a place. Endoscopic cyclophotocoagulation might have a place, but it should be done internally and should be part of other surgeries. What are the other surgical options? Are you going to do minimal invasive glaucoma surgery, or are you going to do shunts or setons, or are you going to do traditional trabeculectomy? We could say we have a lot of surgical modalities available. The newer surgeries do not appear to consistently achieve a low intraocular pressure required for patients with advanced glaucoma. And traditional trabeculectomy is one of the most important if we could have a chance to do it once and to repeat it in another place. Otherwise, we have to resort to shunts. Filtering surgery in advanced glaucoma, it is not such a safe surgery to do it simply because filtering surgery can result in a drastic complication with loss of the visual field and visual acuity by a variety of mechanisms. You could see it here from wound leak with shallow anterior chamber and hypotony maculopathy, and macular folds, as you can see here, which is a very drastic complication. And it might exaggerate the visual loss. Shallow anterior chamber with intracorneal touch followed by lens opacification was found to be the main cause of early visual acuity loss after trabeculectomy in several studies. And we should keep eye on preventing such a kind of complication. To also, wipe out phenomenon, especially in advanced case of the disease, should be warned about, despite the fact that it had been debated and rare. However, it does exist. What are the wipe out phenomena? It is loss of the central field in the absence of other explanation as a cause of postoperative loss of visual acuity. We should keep it in mind and know that it could happen with anyone. What are the guidelines suggest? The guidelines suggest that trabeculectomy remains a conventional primary surgery for advanced glaucoma, but techniques has evolved to include the use of wide application of mitomycin C, employment of reusable suture, controllable sutures with extensive post-operative manipulation. This is to do two things: to improve the outcome of surgery and to make the trabeculectomy a safe surgery in advanced cases of glaucoma. The National Institute for Health and Clinical Excellence guidelines of the United Kingdom has recommended that patients who present with advanced glaucoma should be offered primary glaucoma surgery. And don't wait and give medication because you are losing time and progressing, let the disease progressing and put yourself and the patient in a difficult situation later on. But if we are doing trabeculectomy, there are several tips we have to put in our mind if we are doing trabeculectomy. Preoperatively, we have to consider the risk of any form of surgery should be explained to the patient in advance, in addition to the patient caregiver and his relatives, for sure. They should listen that we are going to minimize or to stop the progression of the disease. We are not going to increase the patient vision. We are going to preserve or try to delay the patient visual loss. Patients should be told that the risk of loss of their remaining field, wipe out phenomenon, could exist, but never, ever discourage the patient from doing surgery. Consider the use of topical steroids preoperatively, like fluorouracil for a week. Lower the intraocular pressure with mannitol or acetazolamide if the intraocular pressure is high, if you need it. If intraocular pressure is still very high at the time of surgery, consider a small paracentesis to slowly decompress the eye, and don't do trabeculectomy in an eye with high pressure. Decompress the eye first to prevent complication. If we come to anesthesia, such a kind of patient usually are elder, so general anesthesia is better to be avoided, but it might be indicated in some patients. Topical or subthermal anesthesia is preferred if the patient can cooperate. Use of peri or retrobarbal anesthesia could be employed, but we have to keep the volume of anesthetic to a minimum and use adrenaline-free medications. Avoid orbital compression with balloons, Honan balloon, and other pressure-reducing devices. Anti-metabolite use. Anti-metabolite use should be used for every case with trabeculectomy, with any kind of glaucoma, except if contraindicated, like if we have thin conjunctiva, or we have scleromalacia or such kind of patient. Intra and post-operative use of anti-fibrotic agents should be considered to reduce the subconjunctival scarring and surgical failure. Place this anti-metabolites diffusely and away from the limbus to create a smooth diffuse bleb. Technical modulation of trabeculectomy should be employed. Do compress the eye slowly and maintain the anterior chamber throughout the procedure with AC maintainer or viscoelastic or VSS as deemed. Temporal paracentesis or do paracentesis at your dominant hand or at your preferred place so you can reach it early and easily at any time, either intraoperative or later post-operative if you develop loss of anterior chamber or shallow anterior chamber and you need to reform the anterior chamber. Keep the scalp flap relatively thick to permit closure without excessive flow. Use fluorescein to conduct sidle tests to assure that we don't have leakage. Pre-placed suture might be employed for easy and rapid closure. Application of releasable and controllable or laserable sutures to facilitate control of the intraocular pressure post-operatively is very important. Operate early in the morning with a fresh mind and consider checking the intraocular pressure later in the day before sending the patient home. Don't operate advanced glaucoma patient late in the day. You should be fresh and your staff should be ready and concentrating. If a monocular patient is there, consider same day admit and that might need to be treated as blind. Post-operatively monitor carefully to avoid excessive IOP spikes or complication related to hypotony. These complications are detrimental for success and the outcome of our glaucoma surgery in general and trabeculectomy in advanced glaucoma specifically. If we come to this video, I am showing here how are you going to suture this thick flap into place with a loose suture, then apply a releasable suture. Simple releasable suture is very important to be released just on the slit lamp in the office and to do little massage. It will enhance the flow. And don't forget to close the conjunctiva securely to avoid any post-operative wound leak. In another case, if we are going to do trap with phaco, I'm doing the same site. We have to, if you see here, I'm using the thick flap, as we also said earlier. Then I'm employing we can say controllable suture. We use 4 rows here. This is the Beng Hao sutures, which he is a pioneer in that. Then I am applying, in addition to the controllable sutures that could be controlled later on, the releasable suture as well. To avoid the aim of these 2 types of suture. The releasable suture is to avoid early post-operative hypotony, and the controllable suture is to enhance the pressure later on with modification, and also to securely close the conjunctiva because we do have a large wound here, large conjunctival wound. I'm doing a grooves in the limbus, then I'm tucking the conjunctiva into the grooves with a sutures here in a matrix fashion, so nothing is there. Thank you for your kind attention, and this is the end of my slides. It's not that much time, and now it's time to listen to my colleagues for any questions. The first question by can medical cannabis improve vision in people with glaucoma and retinitis pigmentosa? For sure, this is the first question. There's a lot of things about this, but not in advanced glaucoma for sure. Don't lose time with such a kind of things. We have to concentrate on such a kind of patients with some things that will help them immediately. What intraocular pressure highest eye can be operated? For sure, we cannot operate on an eye with high intraocular pressure, our otherwise it will explode in our face. We have to slowly decompress the eye through a paracentesis or give a preoperative diamox intravenously. This is very important. Another question, what is your honest assessment of selective laser trabeculoplasty in advanced glaucoma? In advanced glaucoma, I'm not using selective laser trabeculoplasty. I'm using this kind of lasers in moderate glaucoma cases or early in advanced glaucoma cases in order to minimize the use of medication. The other question, when do you order visual field, central 10 degrees, how severe visual field, the central 24-2 that I should order? Number one, every case with advanced glaucoma, we should do central 10 degrees. This is very important. Any new case with advanced glaucoma, even without advanced glaucoma, we should do both. As I showed in the example that early cases in which no visual field loss was seen in the the 24-2, we could find some defects in central part of the visual field with central 10 degrees. Other question, can trabeculectomy be done under general anesthesia? For sure, but our patients are usually elder. If you can avoid general anesthesia, this is very important, but you should do a careful local anesthesia, and it should be tailored to the patient. How often do you order visual field, OCT, disc photos in advanced glaucoma? We should say that visual field, as long if you review the visual, for advanced glaucoma patients, especially the elderly, it is very tireful, specifically central 10 degrees. And it's time consuming and very difficult to do. But if you are reviewing the patient's symptoms and you are assessing that the patient is stable, you could do it every 6 months. But usually we follow up these cases every 3 to 4 months. So not every visit we have to do, but disc photos, it adds nothing to our things, because disc photos we have near total optic nerve cupping, nothing to be seen. Early in the disease, you can control and do OCT and do photos and do everything. But later on, visual field is the only valuable modalities of following up such a kind of patient. What about the primary surgery for advanced glaucoma patient? I could say that for every patient with advanced glaucoma, I advise primary trabeculectomy, specifically if he didn't have any contraindication. I usually don't lose time with medication. Glaucoma is primarily a surgical disease. If you are treating a patient with medication, for sure you should resort to surgery later on. Don't put yourself and the patients in a difficult situation. There's another question about the micropulse rule, preferably in which stage of glaucoma. Micropulse, for sure, it's very important if we can do it in patients with very limited visual field, with advanced stage of glaucoma, and who are not going to live enough with short life expectancy. Can laser iridotomy help in preventing wipe-out phenomenon? For sure, nothing can prevent it, but because we don't know exactly what bring it into the field, nothing could be done to avoid it, but you should be aware that it could exist and should put it in your mind. How many cases of wipe-out phenomenon syndrome in your practice? Luckily enough, till today, I have one, but I will not be happy to see it again. It's very difficult, and I met a hard time to see a patient who lose vision while I'm trying to help him. What are your thoughts on use of the newer 24-2 theta faster algorithm? For sure, visual field is very important part of our basic glaucoma management, but here we should concentrate on the central 10 degrees, which give us more details and more objective follow-up. Would you advise doing trabeculectomy in eyes with vision worse than hand movement? I could say I did not only trabeculectomy in a patient with worse than hand motion. If you see that the patient see hand motion, this type of vision and this amount of vision is very helpful to preserve his dignity and to let him see ghosts and not to be in a dark world. I could do trabeculectomy in such a kind of patient for sure, but we should warn the patient, what are you going to do? Can we replace trabeculectomy with transscleral diode laser cyclophotocoagulation? For sure, till now, no, simply because cyclophotodiode is not quantifiable. You don't know exactly, is it going to work or not? Is it going to have, not, it doesn't behave the same with every patient. It is not successful for every patient. Trabeculectomy is a tested surgery. In your clever hand or in a cautious hand, it could give a better result than any kind of surgery later on. What is the best medical treatment for patients with drug allergy but don't want to do surgery or laser? We said that prostaglandin analogs, carbonic anhydrase inhibitor, and the beta blocker in this kind, first choice, second choice, third choice, in patients with allergy. But what kind of allergy, I don't know. But it depends, because nothing could replace surgery. It is selected in some patients to do some medication because they are not going to live enough. So don't submit them for surgery. Their general condition don't permit to do surgery, or usually they are not able to do surgery. Follow-up strategy in advanced glaucoma, the question by Imran Ali. We could say that usually for stable patients, every 3 to 4 months, don't be late, otherwise you will lose. We should see these patients more often, but if we have progressing disease, we could see it more often than 3 months. If this patient is 260 vision with a near total cupping, which should normal intraocular pressure with multiple checkup, how to do medical management in such cases? If you have a patient with 260, which is, in my point of view, is a very useful vision to keep the dignity and allow the patient go to the toilet and to eat and know to whom he is talking. It's very important to preserve this vision. And sometimes we have patients with less vision than 260. We have to do surgery, and don't submit for medical surgery except in the selected patient with the conditions that we said in the presentation. How to choose medications for advanced glaucoma? We go to the safest and safer. Advanced glaucoma patient, most of them are elder and have cardiac disease and lung disease as well. So beta blocker is a third choice. The first choice is prostaglandins, and second choice is carbonic anhydrase inhibitors. If a patient with advanced glaucoma is against having surgery and the use of advanced glaucoma medication do not reduce the intraocular pressure to low teens, but more mid-teens and low high teens, like 18 or 19. Are there any other things do you use? For sure, we could resort here, if he is refusing surgery completely, you could resort to micropulse or subthreshold laser in this kind of patients. It could be used here as an adjuvant with cautions to avoid any post-operative spikes. This is the most important place of subthreshold laser and cyclophotodiode as an adjuvant for medication for those who are refusing to do surgery. Why the first choice surgery for the primary glaucoma? Why can not follow under medication? No, it's clarified enough that under medication, if the patient is losing his vision while observing him to lose while doing medication. If you catch the patient with advanced glaucoma, what are you going to wait for? Nothing to be lost. If you will be met with complete loss of vision and no target to be saved here. Are there any possibility to improve vision in patients with advanced glaucoma nowadays? I could say for the time being, no known way to improve the vision, but for sure, those who went to the moon and Mars will find a gene therapy and these things to improve this kind of patients. My patient had 40-50 millimeter mercury. He feels not much pain, refractive to medical treatment, visual acuity, light perception. What should I do next? Laser surgery or just let him be? This is 40-50 millimeter mercury are not going to be treated with any kind of laser. You should do trabeculectomy for this kind of patient. Even if he see light, this is enough for him. But don't lose time and try to do medication or laser for this kind of patient. Because the window for laser work is very limited. It is not like trabeculectomy can reduce the intraocular pressure post-operatively from 40 to 10 in a controllable way. If you employ here a controllable suture and erasable suture, you could do trabeculectomy safely in this patient and to keep him on light perception instead of no BL. Can I ask for a patient 36 female with left only eye, right eye blind due to glaucoma? This is a typical for advanced glaucoma. Left eye has 2 failed trabeculectomy and 1 Ahmed valve done 10 years ago. Intraocular pressure now raised to 10 to 26 millimeter with all medications available. I'm not sure is it 10. If it is 10, it's okay. But if it's 26, for sure it needs surgery. Cup disc ratio is 0.7. Cyclophotocoagulation done 2 times with transient effect. What is the next choice? Second glaucoma implant, it's possible, or to review the valve. If you have a working valve, for sure there's something, is either the valve is obstructed or there's some tenon cyst or something like this. You should review the valve, the existing valve, and to assure that there's no encysted perivalve space. What is the best non-surgical treatment in advanced glaucoma? We could say that there's no best non-surgical, but we could say that we might have a non-surgical way in patients who refuse to do surgery, because trabeculectomy is the golden solution for that. For sure, if we want to do some patient with advanced glaucoma might not be a candidate for trabeculectomy and might need glaucoma drainage devices, but glaucoma drainage devices with any sort of complication will not be tolerated for advanced glaucoma patient. Are there particular risk of endothelial incompetency with subsequent bullous keratopathy in patients with advanced glaucoma while operating them for cataract surgery? I operate a lot of combined cataract and glaucoma surgery. Usually the lens and the endothelium is affected, but you should utilize copious amount of viscoelastics and to do little manipulation. I usually do nuclear in situ division of the lens and with the minimal manipulation, for sure. If the patient on medical treatment and he did trap surgery, how we can arrange his medical treatment after surgery? If we did trap for any patient, you should ask him to stop all the old medication, specifically the anti-glaucoma medication, and start a new one. If you are using, don't start with if we don't have complete success with trabeculectomy and we think that this patient is going to fail, you have to resort to revive this bleb earlier, either with laser suture lysis or digital massage, or to do revision of the bleb with needling and injection of 5-fluorouracil or sometimes mitomycin C. But if we don't succeed to get this bleb into function again, we might give him carbonic anhydrase inhibitor, or later on, if there's no inflammation, we could give him prostaglandins or beta blocker if there's no contraindication. Can micropulse diode transclear cyclophotoirradiation be used in advanced glaucoma patient? We said yes, in very limited, as an adjuvant, not as a primary treatment. Used as an adjuvant, if specifically if we need to decrease the intraocular pressure by very few millimeter mercuries. But high intraocular pressure, cyclophotodiode is not candidate for this patient. If I have a female patient, 19 years old, with glaucoma's vision loss, right eye 0.95, left eye with a tunnel and visual acuity 618, being managed with medication, would you advise trabeculectomy for such a patient? Do it immediately, don't hesitate. I do think that the one who will be blamed for advancement of the glaucoma medication is the non-experienced one who is hesitant to take a decision to do surgery. If you try to do surgery for patient with glaucoma earlier, you will revive his vision. You will try to avoid loss and control him earlier. To inform the patient before surgery, do you have the incidence of wipe out after surgery? I don't have the incidence for sure, but I know that I'm telling the patient exactly what are we going to do for you is to try to preserve your vision or to delay loss of your vision. If you choose not to do and your intraocular pressure is still high, you will completely lose your vision. You should say it loudly, for sure you will lose your vision. If we do surgery, the outcome might be you will be preserved, or you lose a little, or in very few cases and rare cases, you might lose it completely. So he have to share your decision. Tell him that he is going to lose his vision if he didn't do. If he did, he will get one of three. In rare cases, he will lose, but now, not after months or something, or might still the same as he is now without any problem, or might decrease the vision a little bit, but remains. Would you advise trabeculectomy in eye with no BL? Only I do it in no light perception in a painful eye. Non-painful eye, no medication, no surgery. This is a malpractice. Only indication for surgery is to stop pain. What medication is preferable for patient with asthmatic and cardiac cases? Asthmatic patient, for sure, we should avoid using beta blockers. And cardiac patient, we should cooperate with the cardiologist. And we have carbonic anhydrase inhibitors, and prostaglandins as well. At the age of 30, both eyes cup disc ratio 0.5 and 0.4 with no other symptoms is normal or need any concern. Patient is myopic of both eyes -3. If you have a patient, this patients with 0.4, 0.5, it might be normal. We should see the patient's family. Number two, we have to do center corneal thickness measurement. and we have to put this patient as a suspect, specifically if the patient cup is deep. Shallow cups of myopes, this is usual. But if the cup is bunched out, this means that something is going on or might be an early perimetric glaucoma. When trabeculectomy fails, do you try it again in another site on the same eye of you, or you move straight ahead to tubes? I do tube always with Ahmed or Barveld if I have no site to do trabeculectomy. I can do trabeculectomy once and twice and thrice and revise if I can with mitomycin. If I don't have this place, it's still a time for cetones, because once you open one quadrant, it is not only one quadrant, it's one quadrant and parts of the other quadrant. So you lose at least 1/3 to 1/2 of the entire subconjunctival space. You will not be able to do. And if he rides the flight of anti-glaucoma valves, he will not be back to trabeculectomy again, because it will fail completely. But if you did trabeculectomy and it fails, still we have time for the valve. Perimetry as a follow-up in advanced glaucoma with light perception. How are you going to do light perception? It's not possible to do perimetry for a patient with light perception. Never do imaging modality for such a kind of patient. It will not be capable of doing perimetry, and you just control the intraocular pressure and listen to the patient symptomatology and manage accordingly. Do you use Ahmed valve? For sure, I use it. I use it for more than 30 years now. Since I was by the end of my residency, I started using Ahmed valve. But not in advanced glaucoma, except if no place for trabeculectomy. Trabeculectomy is my preferred choice for glaucoma, even glaucoma with neovascular medication. In neovascular glaucoma, I do trabeculectomy after control of the bleeding, the bleeders and the new vessels. If you control the new vessels enough, you could do trabeculectomy safely and to minimize to go to Ahmed valve or Barfeld or other things. In other case of advanced glaucoma with visual field 20/20, in case of advanced glaucoma with a visual field 20/20, with a tunnel vision, how can we encourage patients to do surgery with the possibility of losing that central vision? I said, these are the most, if I catch the patient with 20/20, we have to do trabeculectomy now, not tomorrow, because this is the most important and candidate patient for surgery who is going to be benefited. He has the maximum vision you need, and he has the potential. And for sure, the structure integrity for patients with 20/20 is higher than those with 260 or counting fingers at 50 centimeters. I managed to do valve for a single-eyed kid, 7 years old, with repeated glaucoma surgery, secondary to cataract surgery. And luckily, I managed. I was lucky with this patient, but this patient has 160 and he's still in his school with vision aids. So it's very important. If you have a patient with 20/20 vision, this is a very important candidate to tell him and explain him explicitly his need for surgery and the benefit of getting surgery earlier, and the disadvantage of not going to surgery later. Should I start medication on the first visit to 70 years old patient with high cup disc ratio 0.8 and intraocular pressure 10 millimeter mercury without confirmation of visual field test? We should go systematically. Usually, we should try, if this patient 70 years old can do visual field test, is very important. Otherwise, you should carefully document and do photos for the optic nerve head as well. And it's very important. Intraocular pressure of 10 millimeter mercury is okay. Previous LASIK and hard to obtain a reliable intraocular pressure. Measurable intraocular pressure always 12. What should be done? This patient with advanced glaucoma with LASIK, there is a post-LASIK formula, and we have some equations for assessing the patient with refractive surgery, either LASIK or radial keratotomies or post-keratoplasties. This is very important to follow this patient carefully. The most important is not to consider only the intraocular pressure, but the symptomatology, intraocular pressure, visual field if I can do, and the optic nerve head and the retinal field layer if you can see. Can we do minimally invasive glaucoma surgery instead of trabeculectomy in advanced glaucoma? Sure, we can do it in some cases, but which cases? The cases that needs a small millimeter mercury's decrement from the original one. If we have a patient who is 18 or 17, something like this, and we can afford the minimally invasive glaucoma surgery, and you are familiar enough to do it, you can do minimally invasive glaucoma surgery for this kind of patient. Thank you for your patience. It was my pleasure to join you, and I hope that I delivered something of importance to my colleagues.